Welcome to third of Istanbul-Africa Health Meetings. My name is Yusuf İhsan Özdilek, fifth grade medical student at Istanbul Medeniyet University and president of Young MASAM student community. MASAM is abbreviation of Istanbul Medeniyet University Africa Health Training and Research Center. We are proud of organizing this international meeting with such precious participants like you. We are very pleasured. First of all, today is 25 May, and it's Africa Day, as you know. I wish a happy Africa Day to all my friends from Africa and to all African people. I want to say something about history of Africa Day. On 1963, 25 May, Africa made an history with the foundation of the Organization of African Unity. The Union is to celebrate and acknowledge the successes of the organization African Unity from its foundation in 1963, fight against colonialism and apartheid, as well as the progress that Africa has made, while reflecting upon the common challenges that the continent face in a global environment. And today we'll talk about obstetric fistula. I want to talk a bit about it. Dr. Shukri. Although the incidence of obstetric fistula has become rare in the developed countries, it's still a common problem in developing countries. Estimates that at least 1 million women have unrepaired obstetric fistula, and approximately 100,000 new cases develop each year in alone. Probably the most important factors contributing to the high incidence and prevalence of obstetric fistulas in Africa are socioeconomic. And obstetric fistulas are particularly prevalent in parts of the world where emergency obstetric care is limited, nutrition is poor, and there is an early age of marriage. The physical trauma is often accompanied by social trauma, and many women faces problems about it. They got divorced or abandoned because of their subsequent urinary incontinence. So it's a big problem in developing countries for women. Now I want to introduce Dr. Shukri Mohammed. Doctor, welcome. We can't hear you now.
Yeah, thank you, Yusuf, and the rest of the participants. I'm very glad to talk about this topic in 25th May of the Day of Africa. And this is a devastating disease or injury to women, and is a challenge. It was a challenge. It is a challenge, and if we don't do anything about it, it will be a challenge in Africa for the coming years or decades. So I will straight go ahead and start.
Before it, I would request to give some information about your education history. I'm sorry. Dr. Shukri Mohammed is our lecturer today. She had been a registered nurse in Edna Adan University Hospital between 2000 and 2003. And after that, in the Edna Adan University Hospital again, she was midwifery until 2004. Between 2005 and 2011, she was Bachelor of Medicine and Surgery at Emote University. And from 2015 to 2017, she was general surgery in COSEXA, and from 2018 till now, she is a general surgery resident at Hargeisa University and in Istanbul Medeniyet University via MASAM's education program. And today, we are going to talk about obstetric fistula. And doctor, we are listening to you.
Thank you, Yusuf. And I'm sorry if my voice got lost because of the internet is not good in here. So I was losing some of your voices. But
We can hear you, no
I will
problem.
continue my presentation of tonight. And this is the Horn of Africa where I am from. Okay. This is the Horn of Africa where I am from, and Somaliland is here, so I'm located here. So this is my place in the map. So obstetric fistula is an abnormal opening. It shouldn't be there. It's an abnormal opening between the woman's genital tract and her urinary tract or rectum. So if you see in this diagram, this is the bladder, this is the vagina, and this is the rectum. So this is a hole between the vagina and the bladder. So that's a fistula, or it could be the vagina and the rectum, or the bladder and the uterus. So that's the definition of obstetric fistula. Obstetric fistula usually develops from prolonged labor. Prolonged labor happens when there is a disproportion of maternal and fetal bones, mainly the maternal pelvis and fetal head. And we know obstructive labor is a major cause of maternal mortality. So what happens during obstructive labor is when the head obstructs inside the pelvis, it compresses mother's tissue against the pelvic bones, which is the sacrum. This is the rectal side, or the fetal head against the pubic bone. So this is the bladder. So all this red area becomes ischemic, then dies, then the fistula develops from that pressure or that happened to the mother's tissue. So we know obstetric fistula is preventable. Usually it doesn't happen in the developing country, in the developed countries, but it happens in the developing countries. And I will mention later why it happens in the developing countries. And we include in the list of childbirth injuries. It is treatable if there is an access to surgery, it can be fixed. But it causes an incontinence, stigmatization from the incontinence, from the smell. It causes psychosocial effects. It affects psychologically and socially. And if we combine all of these, it makes the woman to be isolated socially. So obstetric fistula, it affects in women in Africa and Asia 3.5 million. And each year there is a 130,000 new cases in these areas in Africa and Asia. If I come down to where I am in sub-Saharan Africa, 60 to 90,000 women develop obstetric fistula. And there are an estimation of 2 million women live with untreated obstetric fistula. Like 2 million live on this earth without a treatment. In some parts of Africa, they estimate that 1 to 10 per 1,000 live births, they develop fistula. So if I take an example in Ethiopia, which is our neighbor, we are very close, we have the same border. There is 9,000 women that develop fistula annually, and only 1,200 gets treatment. There was one article that mentioned there is 2%, only 2% of women in Africa, in Ethiopia, get the fistula treatment. The rest, they don't. So I will mention later what happens to those who don't get the treatment. Somaliland is one of the sub-Saharan countries that the fistula is common. And also reaching the Millennium Development Goals is also the worst. So reducing maternal mortality and morbidity is one of the maternal development, like Millennium Development Goals. So in Somaliland, we lose 1,300 maternal deaths annually, which means 25 women die per week. Each day, there's a 4 deaths and 1 death every 6 hours. And we are a total of only 4 million people in Somaliland. So you can see the significance of women dying. And if we combine all of these, we are the 10th most highest maternal mortality in the world. Somaliland, most of our women, they deliver at homes. There are few percent who deliver in the hospitals. The reason is they live in far places, the roads are not good, the public transports are not usually available, and so there's no qualified midwives in the rural areas. So we have what we call TBAs, traditional birth attendants. There are elderly women who never had a treatment, no equipment. Sometimes they don't have gloves. They just deliver the baby in Somali huts, under Somali huts, without any proper instrumentation. Antenatal care is very, people going to antenatal care is low in my country. And percent goes to the antenatal clinic. So giving you all the statistical information, I want to add one story which touches my heart every time I see this patient. I changed the name because of she wants her name to be changed because of the stigma from the fistula. So now her name is Sado. She's 15 years old. She lives in a rural area where her parents, usually they have a livestock. It was in Ethiopia and she used to live there. She never been to school. She used to help her parents to take care of the livestock. She got married when she was 14 and she got pregnant. She never attended to antenatal clinic during her pregnancy. One day she started to have a labor at home, and then an old lady, an old woman from the village came to her, and she stayed with her for 2 days to deliver, but there was no progress. The second day, the head of the fetus came out, but the rest of the body was still inside. In medicine, we call that shoulder dystocia, and we learn maneuvers to deliver the baby when shoulder dystocia happens. But the midwife, which we call it's not the real midwife, but the TBA, who never had an education, she didn't know how to do it. So she said, okay, I can deliver the baby, so you can take her to a place. And they decided to take her to Hargeisa, which is the capital city of Somaliland. It was 2 days travel from the place they live to Hargeisa. The head was hanging all that time. They were traveling from their place to Hargeisa. They finally reached to the hospital. The baby was removed. The woman, like soon after delivery, because there was a ischemia and necrosis from the pressure of the fetal head and the woman's pelvis, she developed urine and stool incontinence. And because of Sadie's story, the family are very poor, uneducated. They live very far place from any medical help. And this is a picture which is showing you the life of people who live in the rural areas. This is a Somali hut made from roots and the tree leaf.
I think there is a problem in doctor's internet, as she said before, starting.
Hello.
We can hear you, doctors. Sorry for
Sorry, I
this.
lost my.
No problem, no problem.
Yeah, it happens in Africa.
Yes,
Sorry.
also in Turkey, no problem.
Okay. So the symptoms she developed urine incontinence, stool incontinence, generally, or both. But this lady, she developed both. And sometimes they present with urine in the menstruation, which happens when there's a communication between the bladder and the uterus. But they don't only develop fistula. There is other problems or other injuries that is combined with fistula, which is they develop nerve injury and ischemia to the lumbosacral plexus. Well, that affects their walking. Sometimes in the beginning, like soon after the delivery, they become bedridden and then they start to walk with difficulties, and it takes time, which sometimes takes years. And so I will like talk a little bit about the psychosocial effects. And so there's a huge change in their lives. Majority, they are either separated from their spouse or divorced. They don't have homes, they don't have jobs, they are socially isolated, and they don't have children, because we know fistula happen maturity in the first pregnancy. And usually that child dies at that time, and they don't conceive another pregnancy because they don't have either husband, or they develop some sort of infertility because of the stress, because of the malnutrition. So majority, they don't have children. So they are very much socially isolated, and that's also, it affects their psychological like decision makings and self-esteem. So if you see the next picture, whatever you do, if you try even to start communication, they don't give any eye contact. They are depressed. They may fake the smile, but they don't make any communications. If they make the communication, is either they are looking down or looking away from you. And they are alone. When they come to the hospital, they don't have clothes, they don't have food, they are malnourished, and there's no one with them because they don't have money. They cannot use pads, and that's why the urine is going into the floor. There's a smell everywhere. Nobody wants to sit next to them. The age it happens is a very young age, because here they get married in very young age. Around 15 to 23 is the mean, but it can be even younger than this. And they don't go to the health centers because maybe they don't have a transport, maybe they don't have money or education, which means they don't know what's wrong with them, or they don't know where to go. They don't know a language to use if they go outside of Somaliland. So that's a challenge. And obstetric injuries, we divide into two. Obstetric fistula happens in two ways. The first one is from obstructive labor, which is the pressure necrosis fistula. Also, it happens from destructive delivery, which is traumatic. I will talk about destructive delivery in the coming slides. So Pressure necrosis, it comes from prolonged labor, which develops from an obstructive labor. I talked about this one. There is a pressure compression tissue between the fetal head and the mother's pelvic bones. That's how the fistula develops. And cervical involvement, it happens because we said there's a fistula between the bladder and the uterus, but it's less common. And usually it happens when there is a cervical tear, which happens during obstructed labor delivery. The complication of this prolonged labor, pressure, necrotic fistula, we said, it causes fibrosis in the vaginal area. So if the fibrosis and the scarring happen in the vagina, then the surgery access will be very difficult because you cannot stretch a necrotic area which fibrosed. And also it will affect the healing after the surgery. And so if I talk about traumatic obstetric fistula, it happens when we do instrumentation. For example, there is a fetal death. The fetal died inside, like craniotomy. We do craniotomy in here. Usually, I don't think craniotomy is applicable to the developed countries, but we do craniotomy in here, which means if you don't have an access to instrumentation of doing cesarean section, or you don't have the knowledge, it's easy to do craniotomy. Just make hole in the fetal head, try to crush the fetal head bones and pull it. But what happens is during instrumentation, you can make hole either in the bladder or the rectum, or the bones of the head that you crush it can hit either the bladder or the rectum. What also can happen is rupture of uterus during prolonged labor. That rupture, if it happens in the lower uterine segment, it can cause an injury to the bladder. What also happens is when rupture happens, as a doctors, we try to remove the uterus, do hysterectomy. So if we try to make hysterectomy very rapidly, like not focusing on the anatomy, you can cut the bladder and easily you can make a fistula. And that's an easy mistake, but it can affect a life of a woman. So fistula is classified into, or we can group into either the size, and the scarring. Why are we using this? It will help us to understand the outcome of the surgery, the successful rate of the surgery, and also you will give some hints to the woman and tell her, okay, this is a very successful surgery and you will have a very good life afterwards. Or you can tell, okay, this is a very bad fistula, you will have some sort of incontinence in the future. So this will help you that. And also it will help you what type of surgery do you want to do. And so if we divide into, if you come to the site, it could be next to the urethra. We know our mechanism of control is near to the urethra. So this is a very bad fistula. It could be a mid-vagina, which is very good, near to the cervix, very difficult to repair, but it usually happens to women who had multiple deliveries or cesarean section. And it can happen in the cervix, and that usually happens after cesarean section. So this is those we develop as a health professionals. Fistula also we classify as a circumferential. Circumferential means if you see this picture, for example, this is the bladder. In this anterior side is intact, but the posterior, this is the fistula. So this is not circumferential. We call this one circumferential. One, the bladder, there's a hole both anterior and the posterior side. So the whole bladder is separated. You can see this is the urethra and that's the bladder. So this we call circumferential. It's usually difficult to repair and there is some complications after repair. And it has some degrees because, you know, circumferential, it could be mild, it could be moderate, it could be severe, it could be very severe. You can see how much bladder is lost. You know, if you try to repair those, the bladder will be very small, and anyway, there will be some sort of incontinence because of small bladder. The size also will be affected the outcome. If it's a very tiny, very small hole, it's very good. If it's small to this size, or moderate, or large, or very large, which is we call extensive. Those large fistulas or extensive, this is the one we are saying it will affect the bladder capacity, and they will anyway develop some sort of incontinence because of a small bladder. Scarring is also comes from obstructive labor. When there is a prolonged pressure to the tissue, the scarring can make a stenotic narrowing of the vagina. It will affect our surgical technique. It will affect also our outcome. Usually the site it happens is the mid vagina. That's where the obstruction happens. And any fistula with scarring is not it's not for beginners. I mean, it's not for a junior doctor, because it needs a lot of experience, a lot of techniques. So if there's any stenosis, it's not for a junior doctor. But here in Africa, there's no that much of rule. Anybody can do anything. So that's why most of our patients, they have multiple unsuccessful surgeries, and they end up having a small bladder and incontinence for the rest of their life. And so we use a classification systems. The reason we use classification systems is you to organize the type of surgery you are going to do, and also to understand the outcome of your surgery, and also to educate the woman about the outcome of her surgery as well. So this one is Gorham's classification system. He used these 3 steps. The length of the urethra. If the urethral length is long, it has a good outcome. If the urethral length is short, which means the bladder involved in the urethra, the outcome is bad. The size of the fistula also, if it's too big, the outcome will be very bad. If they is small, the outcome will be good as well. And the scarring, we said, if there's a scar, it will affect us in every way, the healing, the surgery, the outcome, everything. So I don't want to go into details, because I don't want to make you all a fistula surgeons, but this is a small hint, like urethral length. If the urethral length is more than 3.5 centimeters without a fistula, that's a good outcome. That will cause a good outcome after the surgery. If it's 2.5 to 3.5, still there's some outcome which is good. But when the urethral length is 1.5 and there's a fistula, or less than 1.5, the outcome will be very bad, because the urethral length is very short. The control mechanism is distorted, and then there will be an incontinence even after a good surgery. So you have to tell those patients about the outcome. And there are some surgeries now for these patients, which is urinary diversion procedures. The size also, as we said, small size, moderate size, and big size. And scarring, we said, if it's scar, if there's no scar, the vaginal length will be okay. If it's moderate or severe scar, it will be reduced. And there are type 3, which is circumferential, we put into type 3. The other classification system is a voltage. Both they are using the urethral length, but the voltage is different from Cohe's classification, is the presence and absence of the circumferential fistula. So we will go into the diagnosis. When it comes to the diagnosis, usually history and physical examination is enough. But sometimes there are a small fistula. So the small fistula usually is not easy to find. So what we do is we put a catheter, we bore a saline with methylene blue into the bladder, and then we put some cottons into the vagina, 3 cottons. And we just tell the patient to walk around for 10 to 15 minutes. Then we remove the cottons. So if the cottons, this is how we do. Put the patient on the bed, put a catheter, just put some methylene blue fluid, and then keep the catheter or remove the catheter or keep the catheter and clamp, and then put 3 gauzes into the vagina. What happens is, if you remove the gauze, the cotton balls, the lowest one, if it's wet and blue, the lowest one, it means the one in the outside. That's stress incontinence, which means the urethral sphincter is not tight, it's not holding. So it comes from the outside. If it's the one next to the cervix is wet and blue, there's a fistula, vaginal fistula. So you have to find that fistula and fix it. So if it's the upper one, the one next to the cervix, is wet but not blue, it means the bladder is intact, but it's coming from the ureters, the one above it. So you have to find those and then re-implant it into the bladder. And so there are causes of failure when you do the surgery. Some of them, they don't heal well. That's why they have multiple surgeries. Some of the causes are infections, local fibrosis or scarring, the one we just talked about it, because any scar has less blood supply and it affects the healing. If there is no good blood supply to your surgical site, the healing is not good. And unsuitable sutures. This also happens in Africa. Sometimes absorbable sutures are not available. So if you use unabsorbable sutures, you need to remove it after the wound heals. Because if you don't remove it, because it's unabsorbable, bladder stones happens, and then they can develop another fistulas. Also, the way you tie your suture, if you tie in between the 2 edges of the wound, then the healing will not happen. So also that will cause a failure. So you have to tie any stitch on a side of your surgical site. So duration of fistula also affects this. This is an important point. For example, if a woman has a fistula for around 15 years or 20 years, what happens is the bladder never get an experience or never get a chance to expand, to collect urine, because of draining the urine from the hole makes the bladder to atrophy, to become small. So if you fix it that, the bladder will take a time to learn to expand, to hold the urine. So they just start pouring urine and they have an incontinence from an atrophy bladder. Number of previous operations also affects the outcome. If they have 3 more previous operations, the outcome will not be good. And also, if you don't give it time. For example, a woman delivered today, she developed fistula, you need to wait for 3 months, all the wounds to heal, and then you can fix the fistula. And you need to do preoperative care. And this is why when we were talking about what they can develop is malnutrition, infections, you need to treat that before you do any surgery. Psychological effects, anemia because of malnutrition, renal insufficiency because of not drinking enough water. You need to do an ultrasound. So you need to treat before the surgery. So the surgery, after you treat, the surgery will be successful. And also you need to work on their neurological damage. They need physiotherapy so they can go back and walk normally. And sometimes they develop foot drop and they limp. And you also need to do a bowel preparation before surgery. You don't want them to strain after surgery. Urinary infections, you need to treat preoperatively, and also after surgery, you need to continue giving antibiotics. Because we know infection is one of the failures of your surgical wound. Skin infections is another issue. Because of concentrated urine, usually they have blisters and wounds in the genital area and the whole perineum. So before surgery, you need to clean it. All the macerated and ulcerated wounds, you need to treat it. You need to teach them how to wash it, all that area, and also you need to treat the dehydration. The issue is they don't drink enough water because they wanted to reduce the amount of urine, so you need to treat that before surgery. And the treatment of these ulcerations and macerations, put some silicone cream, wash it, dry it, put some silicone cream, and put a catheter, because we know even if they have a fistula, there will be some urine collection in the bladder. So just put a catheter, drain that urine, and it will the wound will heal, and then you can do the surgery. Can obstetric fistula be repaired? This is a good question. Surgical repair surfaces, if there is an available surgical surfaces, unfinancially accessible, 80 to 95% of vaginal fistula can be closed surgically. This is a good thing. It can be treated, but it needs an availability, it needs a financial support. And that's why the majority of women, they don't come. This woman, she's 70 years old. She was living more than 30 years with fistula. And after we fixed the fistula, it was her first time to lay down on a dry bed for her first time over 30 years. And that day, she was very emotional because of the success. This other lady, she's young, but she was living with fistula for several years. And I think we talked about this one. Did I go back? So how can we prevent obstetric fistula? It's preventable. We need to educate our in the community about delaying the age of first pregnancy. There are some traditional practices which are harmful to the woman, like delivering at the homes, not going to the antenatal clinics. We need to stop that. And we have to make an availability of health centers that people can go and they can get a good antenatal care. And also we need to increase the training programs for all health professionals, not only doctors, but also nurses, midwives, physiotherapists, and doctors and social workers. So we need to find patients who are homes, who have an untreated fistula, and also we need to have centers with trained health professionals. That's one thing that we can reduce. If we choose all the trainings, I will choose training enough midwives, because midwives are those who can make changes. Like more than 90% of the deliveries are spontaneous vaginal deliveries conducted by a midwife. Few, like less than 10%, needs a doctor assistance. So I think training midwives will reduce the fistula. And so there are some limitations to obstetric fistula surgical treatment in developing countries, including Somaliland. The limitations are there is no enough trained doctors, nurses. We don't have enough fistula centers. Usually we wait a visiting surgeon to come from outside, from the developing country, from the developed countries to come into developing countries. And you know, if you are waiting a surgeon to come, it will be a short period of time, and it will take a time to wait that surgeon. So there is one study, a total of 93 women. More than half of the women, they waited their fistula surgery repair of 1 year. So that's a challenge in Africa. So training local doctors will reduce that, and women can get the surgical treatment early. And any questions? Thank you so much for your attention. And if I talked fast, then I can answer some of the questions.
Thank you very much, Doctor. And if you have any question, you can ask now from chats, or you can talk also. You can wait a bit for your questions. I think there is no question.
Okay.
Thank you very much for your detailed presentation, Doctor. We are so glad to listen to you today, and this was really detailed, and I think there was anything about fistula, and I suppose someone is want to talk.
Okay.
We can listen.
Yeah. You can talk.
Yes, I wanted to supplement something in regards to prevention, because looking at obstetric fistula, like in Africa, it's better prevented than treated, because when we look at the terms of costs, like not many people can afford it. Actually, very few people can afford the surgery, and even not so many doctors are trained to repair the fistula. So it's better we prevent it than trying to waiting to get the fistula, then we treat them. So in addition to what you gave us, I was looking at also prevention, educating the communities about malnutrition, because many studies have shown that malnutrition is one of the predisposing factors to obstetric fistula. Because when maybe a woman is faced with malnutrition while young, the pelvis does not develop well. So in the event that they get pregnant, they are prone to obstructed labor. And when the obstructed labor is not well attended to, they can easily get an obstetric fistula. And another thing is women empowerment, because many women may want to actually access the health care, but they have not been empowered they have not been empowered in the community to stand up for their rights. Someone goes in for an early marriage just because she has been forced into that, but not because she wants. So she ends up conceiving at a very young age, and all these are just risk factors for the fistula. So that was the addition I had. Thank you so much for the presentation. And one more, in regards to complications, fistula causes a lot of social embarrassment to the woman. Like, they live with a lot of stigma, with a lot of depression. These are women who never even come out to go to the market. These are women who will not even go to the mosque just because of the fistula they have. So I find that as a very major complication of the obstetric fistula. Thank you so much.
Thank you. All the points you mentioned are true, and stigmatization is a big issue, and that's why they are so isolated from the rest of the community. And yeah, nutrition is also a big problem in Africa, especially child malnutrition. So it needs a lot of health education programs to the community. Yes, you are right.
Thank you very much for your contribution. If you have any other question, you can interpret. Doctor, thank you very much again. As you said, inshallah, we can do something to save lives of women in future. Now we know the problem. We know how obstetric fistula affects women, and we know its reasons. It's maybe the most important one. And now we need to work hard to overcome. We need to develop science-based projects. I suppose so we can overcome this issue, inshallah.
Inshallah. It will be a good for our communities and for you guys as the junior doctors, medical students. And it will be a lot to women in here who, even they don't have a clothes to wear when they come here, they get support from the local communities in the hospital, so they can get just even clothes to wear. Some of them, they were malnourished for, they were starving for months and years. So when we are feeding them, we really scared for like, what type of food will you start with? We try to consult with the nutritionists because they don't know anything to eat. They were starving for months and years.
Yes, its social impacts are so important also.
Yeah.
I suppose there isn't any other contribution or question. And today, Associate Professor Mustafa Adem Tatlısu is with us also. He's from Department of Cardiology in Göztepe Training and Research Hospital and Faculty of Medicine, Istanbul Medeniyet University in Istanbul, Turkey. And also he's our academic consultant in our young MASAM student community. Doctor, what do you want to say about today about this program?
Okay, thank you. First of all, I would like to thank you for your realizing presentation. I knew lots of cardiology thing in your country, cardiological opportunity in your country, but I knew a little about other areas like here. The doctors and health providers like you will change this in the future. I hope that. And I'd like to celebrate the 25th May Africa Day, by the way. It was very informative for me. I hope our audience will, they will help them to know about the opportunities and capabilities of the health of obstetricians, gynecologists can do these things. But as you said, that prevention is easier than the treatment most of the time. You will change this in the future. I hope that. Thank you again for your nice presentation. And I'd like to thank Young MASAM for this organization. As far as I know, this is the third time of this kind of presentations. All of them was very informative for me. I learned lots of things about health system of other countries. I hope we and they will change this kind of things in the future. Thank you again.
Thank you, Doctor.
Thank you for sharing your opinions and emotions, Doctor. We are so glad to listen to you today. And also we are so glad to work with you in our student community. And thank you all for your attendance. You can keep in touch with MASAM. Now we will share our social media accounts links in chat section. MASAM is abbreviation of Istanbul Medeniyet University Africa Health Training and Research Center. And we do scientific works on educate assistant doctors in Africa, and also we do operations and other examinations and other things about health to improve health in Africa. And now we want to take a photo to have a memory from today. We request you to turn on your cameras to take a photo shoot. We will wait a bit more. And now you can see MASAM's social media accounts links in chat section. You can follow MASAM from these accounts, and you can learn our programs before. Now I'm taking a photo now. Please smile. Okay, I'm taking more. More audiences are opening their cameras. I'm taking again. Okay. Thank you for your attention, your time spent with us today, and your patience. We hope to see you in our future meetings also. Thank you very much.